Hello there, I'm Miranda and this is Take a Moment with NCH&C, the show where we talk to you and your colleagues about experiences that affect you. Listen on your drive between patients or in your downtime, whenever you get the chance to take a moment.
My name is Melissa Goodall and I'm the lead dietitian for the Norfolk Learning Disabilities Service as part of NCH&C. Within the LD service, we're very integrated with social care. Apart from dietitians, we have speech and language therapists, nurses, occupational therapists, physiotherapists, psychologists, psychiatrists who kind of oversee teams as well. And we also work very closely with social care because we know that it's not just one health intervention that is needed. Sometimes it's often an array of those things, and often we can have, for one person, they can have multiple health pressures involved, and you get to meet such lovely carers and family as well, and you're helping them overcome the challenges that it is to support somebody with a learning disability.
That must be really interesting then, to not just have that relationship with the patient and the carers and the parents, but to also have that relationship with, like you say, your colleagues and anyone else in the system who you might need to come across. Can that be quite overwhelming sometimes, with everywhere you need to make sure you've spoken to?
I wouldn't say overwhelming. What I would say, time consuming. I think once you're in the world of the LD, as I kind of call it, is that you realise that for one person, you could have lots of people you need to speak with to make sure your intervention is being put into place. So, for example, somebody might live with their family, so you support the person with their patient and involve their family where you can. They might also attend a day service. So I need to speak to the manager of the day service to make sure they're also following our recommendations. They might have a voluntary job or maybe a paid work scheme that they're also involved in. I then need to speak to them with their consent, if they can, to then speak to their manager at their workplace scheme. They might also, go to kind of a club. There's lots of clubs for people with LD as well that they attend. I might need to speak to the people there, and also with their GP, with other kind of health professionals who are working with them. So for one person, that's a small example.
So what sort of thing are you helping people with?
It can be for a range of different problems. So we see people for kind of weight management, so where they're potentially kind of overweight or obese and need to lose weight. We also have the opposite end of the spectrum, where people might be malnourished or they're struggling to maintain a healthy weight. People with gastrointestinal problems, so things like kind of IBS or constipation, or the opposite, kind of like diarrhea or other bowel problems. People with intolerances or allergies, or things like celiac disease. So they're some of the issues that we face, but it's also about kind of health promotion. So as well as our intervention, yes, we do assess weight, but we're looking at ways that we'll always kind of make sure they're eating a range of foods from all different food groups to meet their requirements.
If someone's got a learning disability and they maybe haven't got the verbal understanding that perhaps another patient might have, how can you help somebody to understand your recommendation and the health benefits of that and why it's so important? Like, what are the biggest challenges that you have with that?
I would say that is one of our biggest challenges. So first of all, I think it's obviously with the client, when we're going out to assess them, one of the things we will look at is, do they have capacity to understand actually why they need a dietetic intervention and to kind of undergo an assessment. We can do a few small things. Can you point to your nose? Can you point to your tongue? Can you point to your tummy? And if someone can't follow those kind of verbal cues, you know, to an extent that they might understand more complex information. But also we would then potentially ask for a speech and language therapy communication assessment, because these are professionals who can assess someone's communication level, and it might be that someone is maybe non-verbal, but actually they can use pictures or they can identify symbols. So we kind of need that baseline assessment first to know how to work with somebody. But if even from doing that actually they don't have capacity, then we would act in their best interest to then work with the people who do support them, so whether that's a paid carer or a family member, basically, in their setting. And I think that in terms of where we've got somebody who has got capacity, but actually kind of low motivation levels, again, that it can be quite difficult.
What's the thing you enjoy the most about working with people with learning disabilities?
We do get some lovely success stories, and it's for the right reason. So, I'm going to go back to kind of a challenge. So I say that one of our biggest challenges is our weight management referrals. So again, then getting people to achieve a healthy weight. It then comes back to, does that person themselves understand healthy eating, but also does their carer or the family member also understand healthy eating, and how motivated are both of those parties? their routine or their lack of routine. So how does food fit around their life, and are they choosing convenience foods, or have they got the time to prepare more kind of nutritious meals? That is one of our biggest challenges. But when we do have a success story, it's really lovely. So for example, I did have somebody on my caseload. We had lots of barriers for their weight, and actually this person didn't have capacity to understand the health implications. But what was helpful was then kind of educating the carers and family regarding healthy eating and looking at some of the barriers together. So, you know, this person also had quite challenging behaviour regarding food. So we kind of got speech and language therapy involved to kind of see what strategy we could place that would help them kind of communicate better. We also involved nursing to do some positive behavioural support planning to kind of manage those behaviours. We had psychology involved as well to look at kind of other things that were happening for this patient who had some mental health issues as well. And it was a very MDT approach. We did have some best interest meetings regarding that and involved about how best to support this person. And it took months, if I'm honest, to get to the place where we were, but they did manage to lose a significant amount of weight that would reduce their implications for developing a health condition. The process was, could be a bit stressful at times, and it was hard work. But when we do get that outcome that we're looking for, it is really nice to hear.
And I can imagine as well, like as a parent or a carer, if your loved one is struggling with their food and their diet, and they only eat certain foods, and that you're going to have a battle on your hands if you try and give them something else, I can completely see why someone would just think, do you know what, we're just going to give them what they want. We're just going to keep it simple, because it's exhausting to have to deal with those battles, especially if they happen so regularly. So it must be very difficult to convince a carer or a parent that is the right thing to do because of the stress involved in that.
Absolutely. And I think that's why, again, like kind of having the MDT approach really helps with that, because then actually have they got a bit of carer burnout? Because if the person they're supporting does present with lots of challenging behaviour, actually the easiest thing to do is to give in to their demands regarding food. Actually, what support is that carer or family member having, and like what can we do to support them as well? So is it that they need some additional support, or do they need some respite care? Again, it's kind of working with the care and family, to see what works with them. And because I think sometimes we do get a bit of opposition, I guess, or a reluctance to change things regarding diet from carers or family sometimes, because it is really difficult, and there is an emotionality regarding food as well. Food is can be quite emotional. So I think that we have to, I guess, be careful about the way that we address it to kind of keep that rapport with family and carers. I think sometimes as dietitians, we get a bit of a bad rep sometimes, that they think that we're just here to tell people what to eat and that's it. But it's about education. It's about actually how can we do this in the most kind of practical way, and which is kind of applicable to them and is realistic as well. We're not going to ask for the world, but it's about those small changes that we can make to somebody's diet that will again achieve that desired outcome.
Absolutely. And you're looking at it very holistically, aren't you? Because you're removed from it. So you can take a look at their health outcomes and think about how it's going to look for them in the future. Whereas a parent or a carer is just in that moment, that relentless day-to-day life. Well, as you say, if they're experiencing carer burnout, then they're going to be stressed and they're not going to want to take your advice necessarily. Also, like you say about, how emotional food is. I mean, we often see it as a treat, don't we? We think, oh, I'll treat myself to a chocolate bar or treat myself to a cake. And that's fine because it's all about balance, as we know. But if you've got a learning disability and you can't make that connection, and you can't necessarily make the decisions for yourself, if you do lack capacity, then you are so reliant on the people around you. And I think that's such a whole, I guess what I'm saying is that's a different side to what you guys do that I'd never really thought about, that you've got to deliver the health outcome for the patient, but actually it doesn't stop there.
No, I think that's the thing. And I think, we involve the patient as much as we can, when they don't lack capacity, but ultimately a lot of our clients don't have capacity to understand the health implications or how to implement, or I think they might have an understanding of health eating, but it's that bit of weighing it up in the balance. And in that moment, can they make the right choice regarding foods? Lots of people know what is good and bad for them. I don't really like those terms, or what is healthy and unhealthy. But I think when it comes to a situation where someone's presenting you, oh, do you want a biscuit? Do you want a piece of cake? I think a lot of our surgeons will struggle to say no, because what they might not do is they think, oh, actually, earlier on in the evening, I've already had X, Y, and Z. And I think it's that also kind of retention and being able to kind of put it into place. And that's where it's really important that we work with their clients and their carers and family to support them in the right way. And it's not about taking choice away from people, but it's about maybe they need some more reminders, maybe some visual reminders, or, it's about actually in a home while they document what someone's eaten.
And I guess that, that's where that communication really comes in, to take the time to really understand somebody, what makes them tick, what is it that they're going through, what have they been through, what makes them turn towards certain foods and away from others. There could be all sorts of things behind that, I presume.
Yeah, and I think the thing, I think we choose foods based on sometimes what is convenient, how much time we've got. I think not always everyone with an LD gets given the right choices. And I think it's the way that choices are presented to somebody as well. So, we would say that if you're going to offer a healthy choice, don't offer, say, a banana or a chocolate bar. Offer a banana or an apple or a pear. I think until you sometimes have these conversations with carers and family, they don't actually realise what they're doing, because you just autopilot and that's what you do. I think until it's that heightened awareness that people need sometimes about supporting them. And that's why when we work with somebody, we would make a nutritional care plan as well that kind of spells out recommendations and how to support them, basically.
It, I think, does come down to what you said, that emotional relationship with food.
Absolutely. And I think that we all care through food. It's someone's birthday, what do we give them? We often give them chocolate or a birthday cake. That can be another kind of challenge or barrier to overcome, because again, if actually this is happening on a regular basis for whatever reason, again, it can then really exacerbate the weight side of things, and people then gaining weight and then becoming obese. And also, food is often used as a way of mitigating behaviours that challenge. So I think if someone is quite maybe demanding or has a behaviour challenge, sometimes people will pacify that behaviour by giving them a snack, and often it's not a healthy snack, because actually that's a distraction. It keeps them quiet for a little bit, in inverted commas. And actually, again, if this happens continuously, then they're getting all these extra calories and it leads to weight. So again, it's that kind of, people need that heightened awareness again of kind of what they're doing. Actually, can we replace food with something else? And also, it's like the opposite as well. People get rewarded with positive behaviour through food again. So it's like, for example, I was working with somebody and he's got lots of health problems. He is kind of obese. He needs to lose weight. He does have capacity, but he needs a lot of support with his food intake at the same time. And he does have lots of demands around food. And we're trying to find motivators for him to change his diet. And one of his carers suggested that if we got to a certain weight, that his reward could be going to Cosmos. And if people don't know what Cosmos is an all-you-can-eat buffet which has a range of foods. But this is quite common that this sort of thing will come up, and obviously you want to hit your head in the palm of your hand, but obviously, okay, well, can we go maybe to a different restaurant? It's an all-you-can-eat buffet.
Yeah, you're right. We just so naturally go to that, especially if food is someone's happy place. What can we do? What can the reward be? Oh, to eat more of it. But so it must be so difficult for you and your team then, because you come in and essentially say to somebody, you can't do any of that anymore. And here are the options, here are the alternatives. Of course, there's a plan, and like you say, it's the MDT and everything. But that must be quite difficult sometimes, I guess.
And I think, again, you have to be realistic, I guess. Yes, we don't go in and say you can't do this, you can't do that. It's education, where you can, involving the client and their carers and families to think, okay, so we've got this end goal. And again, I keep talking about weight management, but there are obviously lots of things, we've got this goal that we need to try and get to stop you from getting these health problems. How can we work with you to put this into place? And it can be just little small changes. And I think that's where kind of, for us, kind of diet history and kind of knowing what someone's routines, what their usual eating drinking habits are. So, okay, so what little things can we change that will reduce your calorie intake, that will actually lead us to, towards that desired outcome? So, for example, if they're drinking full sugar cola, would they consider swapping to like a diet cola instead? We're not taking it away, we're replacing it with something that is less sugar and less calorific. And also, it's about kind of having some agreed dietary goals. It's not about us dictating to people about what they shouldn't be eating. It's working with people to try and get some agreed goals and what is realistic and appropriate for them.
Is there anything you think that the Trust could do to improve the learning disability service?
People should be able to access mainstream services with reasonable adjustments made to support them. But because actually this doesn't often happen, and we are very aware that people with a learning disability do face big health inequalities in accessing healthcare, that is why we are needed within our service. So I think what I would say to anybody within NCH&C who does have a client who has a learning disability is, where you can and if you can, is, and you are aware they've got learning disabilities, kind of get to know your patient well, and actually what adjustments do you need to make to support them. So, you know, if they've got it's a clinic and they've got an appointment time, can they have the first or last appointment of the day so they're not having to wait for long time periods, because that can be quite stressful. A lot of people with learning disability do have anxiety regarding going into, like, say, a hospital or a clinical setting where people look very medical. When they are being seen, you know, can they have a home visit, you know, if that's the environment is more comfortable, or if they do have to go for you to be seen, like, can you make sure it's distraction free in a calm environment? Is there any kind of easy read or information sheet that can be given regarding the appointment, or kind of what your recommendations are so that they can understand the information better? Making sure that they've got someone with them to support them to that appointment, again, if whether they've got capacity kind of or not, but it, you know, if there's some things that's being recommended, then it's about, again, the right people having information so that it can be put into place. Again, they might need a longer appointment time as well, so if it's just that, you know, you've got a 20-minute slot, more than likely that's not going to be enough time to be able to kind of do everything that you need to do, because actually it might have taken 10 minutes for that person to kind of calm down and settle potentially. Do they have a hospital passport as well? So most of our people with an LD should have a hospital passport, and again, that provides kind of really key information about that person, about, you know, their likes and dislikes, and what works well and what doesn't work so well with them. So again, it's taking the time to get to know your patient where you can. And I understand that can be quite difficult when you're very busy and you've got like a full clinic or whatever, but I think it's where that kind of advanced planning, you know, is really valuable.
Thank you for listening to Take a Moment with NCH&C. If you've enjoyed this podcast, please visit the podcast intranet page to leave a comment and for details of our other episodes. You can also follow NCH&C on all social media channels.